We will be starting our breast cancer surgical workshop, and I need on the stage the chairpersons, if you please. دكتور علاء طلعت، دكتور أشرف شوقي، دكتور أيمن عبد الوهاب، دكتور إيهاب سامي، دكتور حاتم أمين، دكتور إبراهيم فخر، دكتور عمر زكريا, and myself. Dr. Ashraf Shawqi, on the podium, please. So I will have the honor to start. يبقى احنا هنتكلم عن multiple lumpectomies for multiple ipsilateral breast cancer. Multiple ipsilateral breast cancer by definition comprises two entities, either multifocal disease or multicentric disease. Multifocal disease means the presence of two or more tumors in the same quadrant with not more than 2 centimeters separating these tumors, and in some publications they went up to until 5 centimeters distance separating the tumors, and these should still be considered as multifocal. Multicentric disease means the presence of two or more tumors, the presence of two or more tumors in different quadrants with a distance exceeding 2 centimeters in some publications, or 5 centimeters in some other publications. وده اللي هم two entities comprised in multiple ipsilateral breast cancer, either multifocal or multicentric. The incidence of multicentricity was reported in serial sectioning of mastectomy specimens to reach up to 60%. And this incidence is increasing nowadays because of the increasing usage of sophisticated imaging techniques like contrast-enhanced mammography or MRI. Nevertheless, even if we detect multicentric disease and are able to remove it, this does not remove the necessity of adjuvant radiation therapy, which is mainly given to the breast to cover for undetected multicentric foci. أصل في رسومات وفي حاجات multicentricity was reported as early as in the 1970s, as you can see in this publication, which found up to 20% of multicentric foci in mastectomy specimens, and that was as early as the 70s. Yet, even in the presence of this high incidence of multicentricity, in this publication of 1985, which is the NSABP B6, it was reported that the disease-free survival and overall survival were even better in patients treated by segmental mastectomy and radiation when compared to patients receiving mastectomy. And in these patients, I am sure that at least 18% had already multicentric disease, which was undetectable. So this trial or this study paved the way for the introduction of breast-conserving surgery in the treatment of multicentric disease. It has been shown and repeatedly shown that for unifocal breast cancer, breast-conserving surgery gave this equal survival outcomes as mastectomy. But when multifocal or multicentric breast cancer was studied, especially in the 1980s and early 90s, 20 to 40% higher rate of local recurrence were reported with breast conservation when compared to mastectomy. So breast conservation was not allowed according to these papers, and mastectomy was accepted as the standard treatment for multifocal or multicentric breast cancer. Nevertheless, all these studies were highly criticized because of inadequate patient numbers, of inadequate imaging techniques used, of inadequate targeted or inadequate therapy used, of inadequate radiotherapy techniques, and inadequate analysis of surgical margins. And then started very shy trials to use breast conservation for multifocal breast cancer, which started with this study by the Institut Curie in France in 1999, which compared wide lumpectomy to mastectomy for multifocal breast cancer, and which reported similar 5-year overall survival and 5-year local recurrence rates in both groups. That was for multifocal only. And then another study in 2015 compared the local recurrence-free survival between mastectomy and breast conservation for unifocal, multifocal, and even multicentric breast cancer, and found almost similar local recurrence-free survival in the three groups, whether they had mastectomy or breast conservation. And this gave rise to many other studies that compared breast conservation to mastectomy in multicentric and multifocal breast cancer, and which all reported similar recurrence-free survival and overall survival. So nowadays, we have three options to treat multiple ipsilateral breast cancer, whether multifocal or multicentric. Either total mastectomy, which means removal of the whole cake, or partial mastectomy, which means removal of one slice of the cake which contains the cherries, which are the tumors, or multiple lumpectomies, which means removal of the cherries separately, each with its own safety margin. And the three are used nowadays. This even led to the change in the Saint-Gallen consensus in 2017, in which the panel strongly endorsed breast conservation for multifocal multicentric disease on condition that surgical margins are made sure to be negative, radiotherapy is given, and adequate cosmesis can be achieved. Finally, very recently, in 2018, the American College of Surgeons Z11102 study was published, and this was a prospective single-arm non-inferiority trial which evaluated the feasibility of breast-conserving surgery in women with multifocal or multicentric disease, and it had a primary endpoint and a secondary endpoint. The primary endpoint was to evaluate the number of surgeries required to achieve negative margins with breast conservation and the risk of conversion to mastectomy to reach a negative margin. And the secondary endpoint was to evaluate the cosmetic appearance and the local recurrence rate after breast conservation for multicentric breast cancer. This is the skeleton of the study. It contained only females over 40 with BRCA negative and who had received no neoadjuvant chemo or radiotherapy. And they all had unilateral breast cancer with more than 2 lesions, up to 3 lesions, not more, with a size of T2 maximum and N0 or N1. The tumor excision was done through single or multiple incisions, and the safety margin was the standard, no ink on tumor. Then whole breast irradiation was given with a radiation boost of 10 to 16 grays to each and every tumor bed, on condition that not more than 40% of the breast would receive more than 60 grays. And these are the results of the American College of Surgeons Z1102 study. As a primary endpoint, the proportion of patients who converted to mastectomy was 7%. And the number of operations performed to achieve negative margins were only one single operation in 3/4 of the patient, and only 2 operations in almost 1/4 remaining in the group of patients. The conversion to mastectomy rate, which was 7%, compares very favorably to many studies who studied the conversion to mastectomy rate in unifocal breast cancer, which ranged from 4 to 11%. So finding a conversion rate of 7% was very acceptable with multicentric when compared to unifocal. The secondary endpoint, which was the cosmetic outcome, found that good or excellent cosmesis could be achieved in 70% of the patients, with no significant difference based on the number of lesions or number of incisions or number of lumpectomies. So 70% good or excellent cosmesis was very encouraging. Also, secondary endpoint regarding the local recurrence rate with multiple lumpectomies, it was found to be almost 3.1%, and when comparing the use of MRI to not using MRI, it was found that using MRI gave a very lower recurrence rate than if you neglect MRI in multicentric breast cancer. Then another trial, which is called the Miami Consort trial, was initiated in the UK, and it was a trial to implement multiple lumpectomies in multicentric breast cancer in a prospective controlled trial, randomized trial. Actually, they started with over 1,600 patients, and at the end, they could only randomize 4 patients out of the 1,600 for either mastectomy or multiple lumpectomies. So because of very strict exclusion criteria and because of lack of compliance of the patients who almost universally refused to have mastectomy, this trial failed and was stopped before it ended. Since we're discussing multicentric breast cancer, I thought this theory called the sick lobe hypothesis, which gave rise to lobar surgery for multiple ipsilateral breast cancer, should be presented here. And this theory started with Sir Astley Cooper, who introduced the lobar anatomy of the breast as early as 1840 in the 19th century. And he suggested that the breast anatomy was made of multiple lobes which opened separately in major ducts in the nipple, and which consisted of 15 to 20 lobes. Now, concerning breast cancer, which starts as a genetic mutation, this genetic mutation that is initiated during embryonic development is transmitted along the lobe where it starts. And this is the explanation of multifocal breast cancer, which is a lobar disease. Sometimes this genetic mutation affects 2 lobes, and this can extend along the different lobes where it starts, and this explains the multicentric disease, which means that it is a synchronous malignant transformation in one or more lobes of the breast. So lobar surgery is based on this lobar anatomy, and it was suggested as a new technique in treating multicentric breast cancer, where you remove the whole affected lobe or 2 or 3 affected lobes without having to resort to total mastectomy. So if you excise through an elliptical incision the lobar segment of the breast that is affected, should it be 1 or 2, and if they are more than 1, they should be related or attached together through a bridge in the subareolar area. This is much easier to close without the need of complex oncoplastic procedures and achieves a satisfactory cosmetic outcome. So, to summarize, it all started with the lobar anatomy presented by Sir Astley Cooper in 1840, which led to the sick lobe hypothesis, which was introduced in the 1990s and which was applied as lobar surgery in 2022. The multicentricity and multifocality, which were found to be present in up to 60% of mastectomy specimens, was discovered in 1970s. In the 80s, the early studies found or suggested that multiple lumpectomies gave a very low local recurrence rate and survival rate when compared to mastectomy. But in the year 2000 and on, more recent studies proved that multiple lumpectomies could achieve reasonable and local control for multifocal or multicentric breast disease. And this ultimately led in the year 2017 to the St. Gallen guidelines endorsing breast conserving surgery for multifocal and multicentric breast cancer. So our take-home message is that multiple lumpectomies for multifocal and multicentric breast cancer is a promising therapeutic option. Nevertheless, it is not yet in the guidelines, and that's because we do not still have prospective randomized controlled trials with adequate number of patients to endorse this surgical technique. And to be able to achieve these prospective randomized controlled trials, we need to take into consideration that oncologic safety is a first priority. We need to achieve acceptable local recurrence rates. We have to ensure that radiotherapy boosts are given to each and every tumor bed, with studying the tissue tolerability to these multiple radiotherapy boost doses, and we have to evaluate and achieve acceptable cosmetic results with this technique. Thank you very much.
Thank you, Professor Sherif, for this very instructive lecture.
ناخد أسئلة ولا تحبوا نخليها في آخر طيب اتفضل اتفضل اتفضل. محتاجين ميكروفون هناك.
Thank you, Dr. Sherif, for this good lecture, but I want to ask about 3 things. First thing, what about the neoadjuvant chemotherapy? If the patient is taking neoadjuvant chemotherapy, is this procedure adequate with it or not? Second thing, what about the skin? If the skin infiltrated or showing redness or any invasion for the skin, I can do this technique or not? Third thing, you are talking about we can do this technique in multifocal disease. Multifocal, the difference between 2 masses is not more than 2 centimeters. Is it beneficial to do this? We're taking safety margin about 1 centimeter. What is the benefit from doing this in multifocal? It may be in multicentric, but multifocal, I think it's not beneficial. Thank you.
Let's take it retrograde. Multifocal disease could be either separated by tumors could be separated by 2 centimeters, and in some by some authors the separation is almost 5 centimeters. So if you follow the 5 centimeter rule, then maybe multiple lumpectomies could be more cosmetic. But if you follow the 2 centimeter rule, I think that if you take 1 centimeter from here and 1 centimeter from there, it amounts to a wide lumpectomy, including both tumors, or a segmental mastectomy. So it all depends on which rule you will follow, 2 or 5 centimeter rule. Now, if the skin is involved, it all depends on what kind of skin involvement it is. If it's only tethering or slight peau d'orange in a localized area, I would remove this skin with the tumor and I would still do breast conservation. But if the skin involvement is widespread, I would definitely go for mastectomy. Number 3, neoadjuvant treatment. The rule in surgery after neoadjuvant treatment is that the surgeon treats the actual situation, the final outcome after neoadjuvant chemotherapy. So if the tumors are 1 centimeter big, you remove 1 centimeter with a safety margin. But if the residual tumor is widespread, then you cannot apply the rules here. If the disease was multicentric from the start, the rule is mastectomy. But it all depends on how widespread multicentric it is. This study I presented had only 2 to 3 tumors maximum. If they had cases with 4 tumors, they would go for mastectomy. So it all depends on how multicentric it is. Is it the number of tumors, is it 2, 3, or more than 3? So the maximum where you can do this technique, according to the authors who endorse it, is 3 tumors. You cannot do it for more than 3 tumors. I hope I answered the questions.
Thank you, Dr. Sharif, for this interesting new issue. It's a new area for me to listen about multiple lumpectomies for multicentric tumors. But do you think, sir, it is better to take into consideration the in situ component of the tumor and the biological behavior of the tumor if we are going to do multiple lumpectomies?
In situ component, you mean surrounding in situ around the tumor?
According to the previous biopsy taken before a surgery, if the in situ component is high or low, does it differ in your decision to take multiple lumpectomies or not?
There was a time when duct carcinoma in situ was a disease treated only by mastectomy. I remember when we were younger, the rule was if you have duct carcinoma in situ, DCIS, then always go for mastectomy because it is a multicentric disease from the start. But then things changed, and now the rule is duct carcinoma in situ is removed by lumpectomy with a 2 millimeter margin to be followed by radiotherapy. This is the adequate surgical treatment for DCIS. So if ever you have an invasive component with DCIS, it should be treated like an invasive breast cancer. If you have a DCIS with a small focus of microinvasion, then you take a 2 millimeter margin to be on the safe side and still go for lumpectomy. I don't think you will find multiple foci of DCIS that are separate from each other, but if they are close, multifocal, then a segmental mastectomy is done. If they are widespread, I would not recommend multiple lumpectomies. To be honest, until today, they are not in the guidelines. So we're only projecting a future perspective for treatment. It is still not feasible unless you do it in a trial.
I think, Dr. Sharif, it's easy to say that at the end you are coming now to the logic situation that you are treating lesions as if they are bilateral. They are of
As if they are?
bilateral. The same discussion was there 20 years ago about the bilateral breast lesion, and maybe 25 years ago the same discussion was about the mastectomy for non-invasive disease, and although that we are going to conservative in invasive. So I think things are getting logic by time, but I think it took us too much time to be logic.
اللوب
السيك لوب اللي هو حسب ما هو السيك لوبس ثيوري، هل انا فعلا عندي اي لاند مارك تاكد لي ان السيك لوب كاملا جه معاه؟
ما هو الاناتومي بتاع اللوبز ده has no gross limits
يعني
او land marks. It has no gross land marks.
انا شايف ان دي حاجه ثيوريتيكال، يعني براكتيكال يعني
it
غير
was
قابله للتطبيق.
I
يعني
thought
هو
it was
مالتيبل لامبكتوميز اوكي، لكن حكايه لوبر سيرجري دي مش
لا. هو وبرضه الحته بتاعه الريترو اريولار بريدج ودي برضه حته
يعني صعبه برضه يعني.
انما it was suggested by authors and I thought it was interesting to show يعني. I don't know if I would do it. But actually I had a case very recently for which this approach could have been very interesting. She had a tumor at 7 o'clock away from the nipple by 5 centimeters, and another tumor at 3 o'clock at the same distance, away from the nipple by 5 centimeters. So instead of 3 o'clock and 7 o'clock, so instead of doing a hemimastectomy, a wide lumpectomy for each of these tumors with a bridge at the retroareolar area could have made reconstruction much easier. So you just do some displacement and undermining and close the defect here and close the defect there. But I had to do a hemimastectomy.
This is imaginary. There is no definite landmark. تعتمد على تقدير الجراح.
يعني النهارده احنا بنقول كده. انا متاكد ان بعد 10 سنين هيبقى هو ده الستاندرد.
هيعرفوا
هيبقى هو ده الستاندرد.
يعني خليني اقول حاجه. هو the same idea about في السوفت تيشو ساركوما لما كانت تاخد لازم مصر كلها، وبعدين دلوقتي بناخد بس الليجن بسيفتي مارجن. I don't believe انه we need to take اللوب من اولها لاخرها اصلا، بصرف النظر ان احنا نروح ندور على الاناتومي بتاعها ونجيبها ولا لا. I think it's about يعني surgical tailoring rather than ان انت you are going to the unit to get it out because you don't need to see the يعني multiple lumpectomies. لا التكنيك ده متهيألي for convenience يعني
هو
مش for ان انت need to get the loop. يعني
السيك لوب ثيوري دي غيرت برضو المفهوم بتاع الفيلد كانسرايزيشن اللي كان موجود عندنا في مخيلتنا زمان، ان هو المالتي سنتريك ديزيز ده زي ما تجيب ملح وتبدره على الارض
يبقى كل البريست
يبقى البريست كله. It's not like that. It is a multi-lobar affection with gene mutation during embryonic life. فهي بتبتدي في اللوب ده وتستمر في الجروث في هذا اللوب. فلو ابتدت في 2 lobes فبتأفكت 2 lobes. انما ما هياش فيلد كانسرايزيشن اللي هو كانك رميت مالجنان سيلز في البريست كله كده مره واحده يعني. ف the concept is changing slowly يعني. دكتوره هبه.
You asked me to repeat the question. Okay. I think it was a comment, not a question, about neoadjuvant chemotherapy requirement for multicentric disease. And my comment was that neoadjuvant chemotherapy is dependent mainly on the molecular subtype and the total size of the multicentric tumors altogether. I think you showed it in your trial here that the total size, it's not really clear, but you showed that the total size should be equal or less than 5 centimeters of all the lesions together. This is my interpretation of what happened in the trial. And I think that neoadjuvant chemotherapy can dictate both the incision that we will make after neoadjuvant chemotherapy and the type of surgery, because according to the response we have, we can decide if we can do it through the theory of the thick lobe segment resection or multiple incisions according to the response. If we have, for example, a complete response, this we can follow only that no tumor on ink should be present on the safety margin that we have, and this will only remove a very small part of the breast. even if it is multicentric 3 lesions. But if there is no response at all, I think this will maybe prevent the breast conserving surgery as a whole, and we will go for mastectomy. And for partial response, according to the size also, because if we have 3 different lesions in 3 different quadrants that didn't achieve a good response, this will make the reconstruction and the incision very difficult for the surgeon and will not also be safe, in my mind, for the patient. So neoadjuvant chemotherapy, if we're gonna give it, the tumors should be clipped, and this is very essential to know, because sometimes we don't go for a clipping of the lesions, depending on the multicentricity, that this patient will not does not fit the breast conserving surgery indication. But surprisingly, in many cases, we can see a complete response, and we say, oh no, why didn't we clip the lesion? We should go now for mastectomy.
To go back to the beginning of the question and the indication for neoadjuvant chemotherapy, whether it should be the summation of the sizes of the tumors, please sit down, the summation of the sizes of all the tumors, or taking the dominant tumor size and stage this patient as according to the size of the dominant mass. Actually, and you said also the biological nature of the tumor. Each of these is a different entity. The biological nature of the tumor will dictate neoadjuvant chemotherapy, aiming at pathological complete response, especially if it is a HER2 positive or if it is a triple negative breast cancer. You aim at complete response, and this will definitely affect survival. So I agree for the biological tumor nature. Now, regarding the size, there is a big controversy nowadays about staging multifocal or multicentric tumors, whether you should take the dominant size and stage it according to this size, or whether you should take the sum of the sizes. They found that the incidence of lymph node metastasis is more related to the sum of the size than to the size of the dominant tumor, but only the incidence of lymph node metastasis. In the guidelines until today, and in the TNM staging system, the size of the dominant mass is the base of the stage. This is what you base your stage on. But there are rising voices that want to use the sum of the sizes together, and they base their theory on the incidence of lymph node metastasis, which is related more to the sum of the sizes than on. It is still controversial.
I think that we should go for, I'm saying that the incidence of the axillary metastasis is very important too, because it dictates also the treatment from the start. If we have a positive axilla from the start, even in hormone receptor positive HER2 negative tumors, I think we should go for neoadjuvant chemotherapy because the tumor is multicentric and there is positive axilla. The response to the neoadjuvant chemotherapy, I know, is not so high in hormone receptor positive tumors, but still, if we can spare the patient like axillary dissection and also improve the whole size of the tumor, if we are aiming for breast conserving surgery, this should be in our mind. So.
المالتيسنتريك disease لو خد chemotherapy, this will not change the surgical decision, because multicentric or multifocal tumors, even if they shrink, they will shrink and remain at the same place. They will not come closer to each other. So you will still have to remove the same area of breast.
It will, and it should be. It will, because if you have a complete
There will-
response,
there-
we will shift from, I have seen an 8 centimeter tumor that achieved a complete
unifocal.
unifocal and maybe 1 or 2 nodules or tumors of 2 centimeter or 3 centimeter. Consider a case with a main tumor of 6 centimeter and 2 other lesions of 2 and 1 centimeter. And you can do a breast conserving surgery. If you give a neoadjuvant chemotherapy and there is a complete response for all the breast lesions, won't this change?
This is a big question mark. If you have a multicentric disease or multifocal disease and you take single biopsies from the residual or the clip and you find that there is a complete response in the two, would you still go for a wide lumpectomy or this is enough?
I think this is enough because we
Dr.
practice
Sharif.
this.
This is the aim of this lecture.
Okay.
This is the aim of this lecture.
Okay.
Okay.
Thank you.
Thank you very much.
Thank you, Professor Sharif. May I present Professor Ahmed State, Professor of Surgery in Mansoura University. He will talk to us. He will give a talk about evaluation of proper margin breast conservative surgery following neoadjuvant chemotherapy.
السلام عليكم بسم الله الرحمن الرحيم. Thank you for the organizing committee for inviting me for this conference. My talk about the evaluation of proper margin in breast conserving surgery following neoadjuvant chemotherapy. We know that the goal of optimally performed breast conserving surgery is to achieve clear surgical margin during initial tumor resection while maintaining the natural shape of the breast. So patients with breast conserving surgery after neoadjuvant chemotherapy may have an increased risk for the development of local recurrence, and we will discuss the cause of this. Nowadays, neoadjuvant chemotherapy has been increased for breast cancer treatment, either for early tumor or sometimes for locally advanced cancer. I'm sorry. The use of neoadjuvant chemotherapy as it has been increased, so we should manage the cases according to the effect of neoadjuvant chemotherapy. We all expecting that the primary tumor will regress in size, and this is a fact in most of cases. But what is important is the pattern of shrinkage of the primary tumor. The pattern of shrinkage of the primary tumor is what will affect the final surgical margin after the neoadjuvant chemotherapy. This figure shows a different pattern of margins. This الماركر بيشتغل ولا ما بيشتغلش؟ Either infiltrated margin in the figure on the left side, or focal infiltration. Previously, we were considering that tumor with margin, free margin, more than 2 millimeter is enough margin, and less than 2 millimeter was called as closed margin. But nowadays, we all agree that incon tumor is sufficient as a free margin, to consider it as a free margin. Several studies have been performed to evaluate the effect of neoadjuvant chemotherapy on the margins or the efficacy of neoadjuvant chemotherapy associated with breast-conserving surgery. One of these studies is this Dutch study. It involved a large series of cases, 63,000 patients with this multi-center study. Here, this studies the most important here is that what we need, this is neoadjuvant chemotherapy here was applied in 8,000 cases. Okay. Is applied for 8,000 cases. 50% of these cases treated with neoadjuvant chemotherapy and breast-conserving surgery. So breast-conserving surgery was performed in 4,000 cases following neoadjuvant chemotherapy. Here, in this series, it shows that involving the margin rate after neoadjuvant chemotherapy, in this case with breast-conserving surgery, was higher in the clinical T1 tumor. Okay, for breast-conserving surgery, as compared to cases with upfront breast-conserving surgery, while it was lower for clinically T3 cases. This is from this study. This is because the study involves several criteria, and this is what is important for me, is the size of the tumor. As I just mentioned a few minutes ago, that the response to neoadjuvant chemotherapy is not usually by concentric form. Sometimes or many cases, maybe up 40%, it shrinks like that in a scattergun pattern or a honeycomb response pattern. This is mammography. This is MRI for evaluation of response to neoadjuvant chemotherapy in a concentric pattern, and this is another MRI for evaluation of a case treated by neoadjuvant chemotherapy, and it showed a scattering pattern or honeycomb pattern of shrinkage. Actually, neoadjuvant chemotherapy on the histological from the histological aspect, it affects the structure of the tumor, either by it causes usually there is reduced cellularity post chemotherapy. This is if the tumor was or the treatment is successful. Also, there will be histiocyte morphology. Also, there will be edema, foamy macrophage infiltration of the area of the tumor. Also, there will be fibrosis. this changes in the histopathology of the tumor will affect the clinical and the radiological evaluation of the tumor response. Pathological response for chemotherapy, there are several methods for evaluation of the pathological response of chemotherapy. Usually we follow this form, the simplest one. This is a pathological complete remission, pathological partial remission, pathological no response. So accordingly, we need to know the response of the tumor, if it is in a concentric pattern or it is not a concentric pattern, if it is a scatter pattern or honeycomb pattern. So if it is like that, so we didn't have a new definite tumor to make a safety margin for this tumor. We have usually multiple foci of the tumor. The techniques that could help us till now is the use of dynamic contrast MRI. Also, positron emission tomography, BAM, are used to help to evaluate the response of neoadjuvant chemotherapy. This figure shows BAM, positron emission tomography, as compared to PET-CT and mammography, ordinary mammography and ultrasound, and was found to be more sensitive and specific than this other techniques. We did study in our center, Mansoura Oncology Center, to evaluate the proper margin following neoadjuvant chemotherapy. Our study was planned to detect the response of the chemotherapy, pathological response. We used the CLIP markers to identify the original border of the tumor, and we give our patient received the chemotherapy and until he finished the course of chemotherapy. So we did resection of the tumor with the original margin and compared the response of the tumor, so we can define the proper response of the tumor, and if we take the new margin, it will be sufficient or not, or will be another lesions in between. The criteria was we selected patients from stage 1 to 3, solitary lesion. We didn't use any, we didn't take any multifocal lesion, and the patient achieved complete or partial response. If there is no response, we will not take this patient into our study. For localization of the treatment, pre-treatment with chemotherapy, we used the titanium clip, and we used also our مش عارف اقول يعني احنا مش انفنشن، هو احنا مش احنا اللي مخترعين، واحنا تتبعناه طبعا احنا بدايه الدراسه دي كانت يعني داخلين على 2016، و2016 بدات يحصل التعويم الاولاني، فطبعا تكلفه التيتانيوم كليب بقت غاليه، فبدانا نفكر، لان انا مش في الحاله دي انا محتاج احط اكتر من ماركر، انا عايز احوط التيومر كله عشان اقدر اشيل الماركرز دي. وصلنا للسيلفر رودز دي، كان تقريبا عرفنا ان في الهنود يعني من لما خلت الشباب يقروا لنا في فوصلوا مع الهنود وعرفوا بيعملوها ازاي، يعني تواصلوا معاهم وبدأنا احنا نستخدمها. نعم، فاحنا استخدمنا الاثنين التيتانيوم والسيلفر عشان نقدر نحدد البوردر بتاع التيومر، عشان نقدر نشيل على البوردرز ديت القديمه اللي هي الاوريجينال، ونعمل باثولوجيكال ايفالويشن. دي صور ام ار اي بري تريتمنت وبوست تريتمنت، وهنا في الواير لوكاليزيشن موجود. سوري، هنا احنا عملنا اكسجن للتيومر، وبنتاكد طبعا بالماموجرافي عشان نتاكد بالاكس راي ان الرودز موجوده في، او سواء التيتانيوم واير او السيلفر رودز موجود في الماس. طبعا زي ما احنا قلنا، ده احنا تشيب الترناتيف تقريبا بعشر، مش عشر، يمكن 1/100 من الثمن بتاع التيتانيوم كليبس لاستخدام السيلفر واير. ده شكلها يعني هو عباره عن زي رول كده، وبنقصه تقريبا الطول 3 سم، 2 ل 3 سم حسب اللينس اللي احنا بنحدده، وبيتحط في باكج ويخش يتعقم، وبعد كده بيتحط في سباينال نيدل، والسباينال نيدل بيحصل لها، بتخش في على الليجن، ويدخل الانتروديوسر يزق السيلفر واير ويطلع ويسيب السيلفر واير يفضل موجود جوه. دي صورة الام ار اي ومتحوط لماس ومتحوطة بالسيلفر رودز. ودي اتعملت بيبر ونشرناها يعني early this year، evaluation of a cost effective method for tumor marking prior to new adjuvant chemotherapy using silver rods. ده شكل السبيسمن بعد ما بتشتغل. المهم ان الفحص بقى طبعا examination للتيومر وللمارجن. طبعا ده التقطيع بيبقى راديال كده، ويبدا تشوف التيومر من السنتر الى البريفري، ولو في اي ليجن ان بتوين بيتحدد، او لو على المارجن الاساسيه حتى في تيومر بيتحدد. نرجع للمهم، للريزلتس بتاعتنا، المهم اللي فيها. طبعا معظم الحالات كان انفكتريتنج داكت كارسينوما كالمعتاد، وليمفوفاسكولار انفيجن كان موجود في تقريبا نص الحالات. الكلينيكال ريسبونس حصل معانا كومبليت ريميشن في 26% من الحالات، كومبليت ريسبونس، الكومبليت كلينيكال ريسبونس. الكومبليت كلينيكال ريسبونس 26 حاله، 26 دولت بيمثلوا تقريبا ثلث الحالات، 34%. الباثولوجيكال ريسبونس كان 20 حاله، اللي هم مفروض 26% من الحالات، اللي مفروض من الحالات اللي حصل لها كومبليت كلينيكال ريسبونس تقريبا 3/4 الحالات حصل لهم كومبليت باثولوجيكال ريسبونس. يعني في ربع الحالات اللي بيحصل لها كومبليت كلينيكال ريسبونس ما حصلهاش كومبليت باثولوجيكال ريسبونس. البوزيتيف مارجن، البوزيتيف مارجن في بالنسبه على البوردر بتاعه التيومر اللي هي المفروض الاوردينري، اللي هي البري نيو ادجوفنت، الاوريجينال بوردر، وجدنا ان في، رغم انهم حصل لهم بارشال ريسبونس، طلع في برضه فوكال انفلتريشن في حالتين من الحالات اللي هي للاوريجينال مارجن، و38% من الحالات على النيو مارجن طلعت انفلتريتد. تقريبا 40% من الحالات بعد النيو ادجوفنت كيموثيرابي بيكون فيهم المارجن للاسف طلعت انفلتريتد. اوكي عشان الوقت الفاكتورز اللي كانت وجدنا ان هي لها رول ان المارجن تبقى انفلتريتد. الليمفو فاسكولار انفيجن كان اهم فاكتور في الاستادي بتاعتنا. In conclusion, breast conserving surgery after neoadjuvant systemic treatment is safe whenever the safety margin is free. To do wide local excision according to the new tumor size carried the risk of infiltration of the safety margin in about 1/3 of cases, according to our study. Risk factors associated with increased incidence for infiltrated post-surgical margin include primary tumor size more than 5 cm, residual pathological size more than 3 cm, lobular histology, lymphovascular infiltration, and if the tumor response, partial response, was less than 60%. We found that as a cutoff response to treatment. When the tumor response, clinical response is good, excellent, so the incidence of infective margin is less than if the tumor response was not enough to, or we can say not reaching about 15% from the original size. So the cut-off mark, our response in our study was 60% response to downstaging or downsizing of the primary tumor. And thank you.
دكتور احمد بيه ناخد سؤالين كده. اتفضل دكتور احمد.
هو تعقيب انا عاجبني حته السيلفر رودز قوي. احنا في عين شمس برضو في الدمرداش عندنا مشكله الفاينانس بتاعت الماركينج للتيومر، فاستخدمنا الكوليسيستكتومي كليب with excellent result. بنجيب الكوليسيستيك طبعا مش احنا راديو دايجنوزس، الكوليسيستكتومي كليب بيقسمها نصين يحطها في ابره الترو كات ويروح عامل ماركينج مابينج براكيتنج وات ايفر بالكوليسيستكتومي كليب، وجايبه ريزلت حلو قوي. لو
بتتفرد يعني
الكوليسيستكتومي كليب بعمل كده،
ما انا عارف بيتفرد،
بنكسره بالنص،
تتفرد ولا تقصه من النص؟
بنكسره بالنص،
تتقص من النص،
من النص
بس تبقى صغيره. هي الفكره انه انت بتبقى عايز
الكوليسيستكتومي كليب قد كده، يعني هو مقاسات.
عايز الكبير بقى، المقاس الكبير اللي هو
اي مقاس. هي اساسا المارك بتاعت الماركينج اللي هي البروبر كليب فيري سمول فيري تيني، فانا ممكن استخدم اي واحد من الكوليسيستكتومي كليب. فهم بيكسروه بالنص، يحطوه في الترو كات نيدل اللي هي التجويف بتاعها، ويروح زقه في مكان التيومر. اكسلنت ريزلت، واحنا وثابت في مكانه وما بيتغيرش. ماشيين على كده بقى لنا فتره، لغايه اول ما بيحصل ديفكت في الكليبات بنستخدم الكوليسيستكتومي، لو رجعت نستخدم العاديه يعني بس حاجه
ده كويس. دي فكره برضو كويسه، بديل كويس.
وكفاينانس معقول قوي.
يعني انا يا دكتور احمد معلش عايز اسال حضرتك سؤال. يعني الكونكلوجن بتاع البرزنتيشن او بتاع الستادي اللي اتعملت في المنصوره، ان يستحسن في بعض الحالات ان انا بعد النيو ادجوفنت كيموثيرابي السايز اوف ريسكشن بتاعي يبقى بيزد على الاوريجينال سايز اوف ذا تيومر؟
لا انا ما اقصدش كده. هو احنا كلنا متفقين ان انا هعمل اكسجن على الفاينل ريزلتس، الفاينل سايز اللي بنوصل له.
حضرتك بتقول ان في احتمالات
لا،
ان
ما هو في احتمالات، بس انا ما هو ايه بقى الحالات اللي تخليني ابقى كوشس. ومفروض انا ببقى عارف يعني من الاستادي دي ومن الكلام اللي اتقال قبل كده انه التيومر ريسبونس مش دايما بيبقى كونسنتريك، فبيبقى وارد ان يبقى فيه
دي اللي هي تعليق برضه عليها،
اللي هو السكاتر باترن ده في الريسبونس.
دي انا ليا تعليق عليها. انما لا، عشان نرجع بس للكونكلوجن، يعني هل في انديكيشنز؟
فاحنا في الحالات عندنا
هل في انديكيشنز
ان في تيومر فعلا ما بين البرايمري بوردر بتاع التيومر والفاينل بوردر اللي كان فيه فوساي من التيومر في تلت الحالات. وده
لا، سؤالي لحضرتك، هل في انديكيشنز معينه حضرتك تنصح فيها ان البوست نيو ادجفنت ريسكشن يبقى على قد الاوريجينال سايز اوف ذا تيومر؟
دي لو انا عملت الانفستيجيشنز راديولوجيكال
هنقول
يعني انا لو عملت دايناميك ام ار اي وذ كونتراست، ولو انا عندي البوزيترون ايميشن ماموجرافي وقال لي ان في اكتر من فصاي، يبقى انا هشتغل على الاولد او الاوريجينال تيومر بوردر. لكن لو
اللي هو
يعني
سكاتر تايب
السكاتر تايب لو ظهر لي ده راديولوجيكال عندي آلة تساعدني، يبقى بالتالي
ده احنا متفقين عليه. هل في انديكيشنز اخرى؟
لا، هو مفيش انديكيشن لان انا ما اعرفش. لكن الفكره ان احنا بنقول انا بعمل الارم ان عن تلت الحالات حسب الاستادي اللي عندنا ما بين النيو بوردر والاوردينري بوردر او الاوريجينال بوردر فيها تيومر.
اللي هم
يعني
مين؟ اللي هم التلت دول اللي هم مين
المساحه
بقى؟
دي
اللي هم مين؟
طلعت انفلتريتد.
اللي هم مين؟
طلعوا احنا لقيناهم في الحالات اللي هي مش عاطيه جود ريسبونس مع الكيموثيرابي، اللي هو احنا قلنا الكات اوف ساين الكات اوف ليفل اقل من 60% ريسبونس. الحالات اللي فيها ليمفوفاسكولار انفيجن، الحالات اللوبيولار كارسينوما، دي الحالات اللي احنا وجدناها سيجنيفيكانت مع التيومر سايز لو بعد التريتمنت كان اكتر من 3 سم، ولو انا بادئ بتيومر اكتر من 5 سم. دولت الحالات اللي كانت فيها شويه سيجنيفيكانس ان هي ممكن يبقى فيها بقايا ليجنز. لا ما عملش على
لا، هي لسه ما وصلتش لمستوى ريكومنديشن، انما هو الارم.
انا ما اقدرش لك الارمنج، يعني احنا لازم نشوف تولز تساعدني عشان ما يبقاش عندي انفلتريتد مارجن. في حاجات انترا اوبراتيف، في تولز بس انا ما قلتهاش يعني عشان الوقت. بس
هل ربطتوا البوزيتيف مارجن بالتيومر بيولوجي؟
ما هو التيومر بيولوجي يعني ما كانش فيه سيجنيفيكانس الحقيقه.
هو كل اللي
هو في نقطه
يعني كان
في نقطه
بس
معروفه
في
نقطه معروفه ان عاده الكونسنتريك ريسبونس او كونسنتريك شرينكج ده بيحصل مع الليومينال تايب،
تمام،
والسكاترد ريسبونس ده بيحصل مع الهير2 بوزيتيف والتريبل نيجاتيف تايب. I think ان this should be studied also.
عايزه تكمل لكن ما كانش
significant
يعني احنا في الاستادي هتلاقي في
related
احنا شفنا الجريدنج
المفروض انك هتلاقي اعلى
ريسبتورز والاي ار
في الهير2 بوزيتيف والتريبل نيجاتيف.
ما كانش في اي سيجنيفيكانس، يعني في فروقات بس ما فيش حاجه سيجنيفيكانت.
طيب معلش
في حاجه مش مظبوطه.
معلش ممكن اسال سؤال؟
احنا عملنا 76 حاله يعني ممكن يحتاج اكتر.
ممكن اسال سؤال صغير؟
اتفضل.
الفصاي دول كان حجمهم قد ايه؟
الايه؟
الفصاي دول كان حجمهم قد ايه؟
لا ما هو احنا كنا بنقارن في الفلتريد مارجن ولا لا، احنا ما دورناش حجمهم.
لا يعني انا يعني اصل في نقطه مهمه قوي اللي حضرتك قلتهم كلهم دول انديكيشن للراديوثيرابي بوست سيرجري، وهو اصلا عين الكونزرفاتيف هياخد سيرجري.
هو الفكره ان انا ممكن ما اعرفش
اقول لحضرتك بس
يعني انا هشيل على النيو سايز
مش القصد مش بص يا فندم هو
وهيديني انكون تيومر زي الفل فري.
لا هو مش ده اللي
انا ب 2 3 مللي فيه فوكس. انا
هو يا دكتور محمد
يعني ده اللي انا اقصده. احنا يعني ما اقدرش، هي دي الفكره بس مش
هي الفكره مش كده خالص.
لا انا لو عارف ان في بقايا هقول ادي راديو ثيرابي يعني بوستر دوز على الاريا دي.
هي بس الفكره اللي انا عايز اقوله ان احنا برضو لازم نخرج من فكره ان انا بدور على المايكرو انفيجن وبدور عليها، لان احنا جرينا ورا القصه دي في الاكزيلا عندنا ولفتت ورجعنا تاني. فهي نفس القصه برضو، ونفس القصه بتاعه البريست ميتاستاسيس وذ انون اوريجين في البريست، واللي كنا بنعمل ماستكتومي ات تايم وبعدين في الاخر لقينا ان الراديو ثيرابي از مور ذان انف، لان هي غالبا كانت مايكرو فوساي. فهي احنا عندنا جود ريزلتس في الكونزرفاتيف سيرجري مع البوست نيو ادجفنت، مش باين فيها ان عندنا.
ما انا عارف احنا يعني انا
انا مش قصدي حاجه،
لا ما اقصدش، انا قصدي ان الحالات اللي عندنا تقريبا قلنا ان تلت الحالات 34%
يا فندم. ما هو
انا فاهم الريت اوف ريكارنس مش كده يعني.
احنا ما ده بنقول
الريت اوف ريكارنس احنا بقول
ده اللي انا بقوله
9%
غالبا هي القصه
فولوينج
القصه ان احنا بنتكلم على غالبا وجود مايكرو انفيجن فوساي في المنطقه بتاعه الشرينكج ما بين الاصلي والبوست، وغالبا دي بتبقى تريتد براديوثيرابي. يعني هو ده التفسير ان حضرتك لقيت finding very important، والفايندنج ده ما هو لا يمثل مشكله عندنا في الريكارنس او في الريزيديال، خلينا نقول بقى في البوست نيو ادجفنت سيرجري. فيعني انا شايف انه الكلام ده
في حاجة بس احنا مش واخدين بالنا منها، هو الستاندرد اوف كير اللي هو نو تيومر اون انك بوست نيو ادجفنت كسيرجيكال مارجن، وان احنا نريفير للبوست نيو ادجفنت سيرجيكال مارجن was based on similar clinical trials that have been done 10 years ago. So this trial is not new, and I found that there is no difference in the positive surgical margin between post-neoadjuvant chemotherapy or systemic therapy, new margin and the old margin. And based on this, it's a standard of care now that we should take the margin according to the new margin, not to the old margin. Because
Okay,
if
we all agree with you. We all
yeah,
there is no
yeah. The second point is that you
There's no
showed
debate
us
about this.
34% or 30% of your cases were positive when we refer to the older margin, but these are only 2 cases, so it's not statistically
2
significant.
cases for what?
You showed us in the number of cases, these were only 2 cases.
Only 2 cases. The older margin was infiltrated.
Yes, yes.
Not the new margin. The new margin was
The new margin is assessed when we do a frozen section analysis and a paraffin section, and if we find it positive, we go again for further resection, and then the booster dose of the radiotherapy is part of the standard treatment. It's not
okay. Well,
yes
I
or
agree
no.
with you. But what I'm trying to say that we may leave a foci of tumor in spite of taking the whole tumor with ink on tumor is free.
Yeah, that's
There is no ink on tumor.
Yeah, that's the role now of the radiotherapy boost that we
Yes.
are giving. We are giving the booster dose because it prevents the recurrence in 40% of cases, and only in very few cases when the tumor is less than.
Yes, in spite of this, if there is focal infiltration of the tumor, the radiotherapist, the clinical oncologist will refer the patient again. He will say the surgeon should remove this again.
So this is an indication
In
for
spite of-
frozen section analysis.
We know that there may be a foci of tumor, but all we need is approved by pathologists. There is no ink on tumor. The
Thank
tumor
you,
is
Dr.
free.
Ahmed. Thank you, Dr. Ahmed. Thank you very much. Now we present Dr. Tariq Salah, consultant of Surgical Oncology, Tanta Cancer Institute. And he will present 2 cases of breast reconstruction using combined latissimus dorsi with silicone implants in immediate and delayed breast reconstruction.
Thank you, Dr. Ehab. I would like to thank the organizing committee for this kind of invitation, and it's a great pleasure to be with my professors and my colleague here in Onco Egypt. Today we are talking about, we'll present 2 cases, one about immediate and one about delayed breast reconstruction by using both combined latissimus dorsi and implant. So, breast reconstruction is an integral part of breast cancer treatment, and nowadays an increasing number of patients benefit from either immediate or delayed breast reconstruction. According to the timing, there are 3 types of breast reconstruction: immediate, which is done during mastectomy; delayed later on after the patient finished the radiotherapy; and what's called immediate delayed in 2 stages surgery. First stage, you may put an expander that is to be inflated later by saline, and after the patient received the radiotherapy, the expander is removed to be replaced by permanent silicone implant. And according to the technique, we have an implant based using a silicone implant as a reconstruction, or autologous tissue such as latissimus dorsi or TREM. And what's a combined technique is implant and autologous tissue. Immediate reconstruction has many advantages, such as it's technically easier, as the patient hasn't received radiotherapy yet, so no scarring radiation, no affection of the skin is pliable. Also, which is very important, is the inframammary fold is easier to delineate. It's a cost-effective. Patient undergo one surgery, not two surgeries. Patient come out from the surgery with a reconstructed breast is psychologically beneficial for her. However, concern about positive margin, which can be solved by using a frozen sectioning, and if the patient is going to receive a post-operative radiation therapy, the complication may appear, especially if you are going to use the implant-based reconstruction. Delayed reconstruction done after the patient has received her radiotherapy. Advantages for it is ensure adequate local control of the tumor, allows for better selection and discussion of the reconstructive technique and the procedure with the patients. However, you have many disadvantages, such as post-radiotherapy affection of the skin, loss of generous part of the native skin, which is very important. Also, inframammary fold is not adequately delineated, so you have to recreate a new inframammary fold. The myocutaneous latissimus dorsi flap, first described by Tansini in 1906 for the reconstruction of the chest after radical mastectomy, and Oliveri in 1976 rediscovered the LED as an option, a major option in breast reconstruction. The LED flap is a flap of the choice because its safety, reliability. It's a highly vascular flap, has dual supply, one from thoracodorsal and the other from segmental lumbar and posterior intercostal perforators. It can be used in both delayed immediate reconstruction. It also can be used if the patient is going to receive radiotherapy, as it can stand well with the radiotherapy. Contraindications for the latissimus dorsi is very rare, such as a lesion in both pedicle of the latissimus and serratus anterior, congenital absence, which is very, very rare, of the LED, pathology of the dorsal spine, such as scoliosis. However, sometimes the volume of the reconstructed breast by the LED may be insufficient, especially if the patient is very thin or if there is marked atrophy of the flap. So the traditional solution for such cases was the secondary insertion of an implant under the flap. The integration of the prosthesis with the LED flap enhances the aesthetic outcome. It improves the shape, improves the volume, improves the projection, so allowing for more natural looking breast. The LED flap provides an adequate coverage of the implant, reducing the risk of the complication with the implant, and can stand also well with the radiotherapy, as we have mentioned before. So, first case is for immediate reconstruction. She is a 45 years old lady. She had left breast cancer, come to Tanta Cancer Center by some sort of incisional biopsy in the upper inner quadrant that revealed mixed lobular and ductal carcinoma. Patient, according to the MDT, received neoadjuvant chemotherapy. She has a multicentric disease in upper inner and upper outer quadrant. Staging is to 2. In one, she had an left axial lymph nodes, and of course, free anesthetic workup. At MDT, the patient required to preserve the volume of the breast. So the plan was for nipple sparing or skin sparing, according to the frozen section. Mastectomy with reconstruction via LED and implant. LED to provide a protection for the implant and provide some volume, and the implant will provide the adequate volume. Here is the anatomy of the latissimus dorsi. It originates from the lower 6 thoracic vertebrae, thoracolumbar fascia, posterior third of the iliac crest, and has interdigitation with the serratus anterior, and inserted in the bicipital groove. Also, it has an attachment to the inferior angle of the scapula. So, in preoperative planning, we should respect this extension if we are going to do what's called the extended LED flap. We have the section from the spine, from the angle of the scapula, and from the iliac crest, and separated from digitations. The proper choice of the site of the skin island depends on what's called the bench test, we have to choose the site of maximum laxity, maximum amount of the fat and muscle, and also we can use the site of the bra to be a little hidden on. So the patient undergo nipple sparing mastectomy, taking into consideration the excision of the previous scar of biopsy. And in these pictures, we can see after the patient after nipple sparing, also axial dissection for level 1 and level 2, and the excision of the previous scar of biopsy. And this is the technique of the extended LED flap. The patient is positioned in the right lateral decubitus position. Flap dissection is starting by incising the skin. Continue dissection of the skin to create the upper flap. Starting the flap by dissection between the superficial fascia and the fat attached to the underlying flap of the muscle. Alice is used to raise the skin. Do the same thing inferiorly. Here is starting the upper flap by dissecting a gap between superficial fascia and the fat overlying and attached to the muscle. The fat attached to the muscle is very important to give the bulk needed for the reconstruction. Starting the lower flap. Starting to dissect anteriorly. Again, returning back to the lower flap. Here is starting posteriorly to identify the trapezius muscle. Of course, the dissection is continued until the spinal process. Here is again to the upper flap to reach the inferior angle of the scapula, which I consider a key point during latissimus dorsi flap. Here is the angle of the scapula. In this area, rhomboid muscle should be identified and preserved. It lies medially to the inferior angle of the scapula. Dissecting again posteriorly to complete dissection of the trapezius from the flap, and care should be taken not to include the trapezius with the latissimus dorsi flap. Elevating the edge of the latissimus dorsi flap. Is complete separation with the trapezius from the flap. Here is the appearance of sacrospinalis muscle and its covering aponeurosis or fascia. It should be preserved as possible. This will decrease the incidence of seroma postoperative. Good hemostasis should be done directly at any time. Again, back to the angle of the scapula. So the superior edge of the flap is completely elevated. And here is the appearance of the rhomboids, trapezius, as well as the sacrospinalis muscle. This is the flap and this is the under knee sacrospinalis. Hemostasis for the perforators. This is inferior dissection, and we do inferior dissection up to the iliac crest or close to it. Posterior elevation of the flap. This is the teres major muscle identified as lateral to the inferior angle of the scapula. Care should be taken to separate it from the latissimus. Again, this is the teres major muscle. So they have an inferior angle. Posterior to it is the rhomboids and anterior to it is the teres major muscle. Starting resection more anteriorly to the reaching serratus anterior. Adequate hemostasis. Separation from interdigitation with the serratus anterior muscle. The section is proceed towards the axilla. Starting to dissect between the skin and the tendon of the muscle to create the tunnel. Here is a tunnel made for the anterior the rotation that will be done for the flap. Still some connection with the digits of the serratus anterior and fascia overlying the ribs. Continue dissection of the axilla. So this is complete harvest of the flap from the posterior wall. The skin island overlying the flap will be completely deepsalized on anterior rotation later on. So we will rotate the flap about 180 degrees through this tunnel. We found some attachment still, so the section is continued. tendon of the latissimus dorsi, so the rotation will be done anteriorly. Avoid any kinking of the pedicle to avoid ischemia of the flap. This is proper hemostasis of the posterior cyst wall at the donor side. Closure, and before closure we prefer to do a trimming of the edges of the back to avoid any necrosis in the edges later on.
بتقطع النيرف ولا لا دكتور طارق؟ دكتور طارق بتقطع النيرف؟
هو في الليتريتشر انت حضرتك المفروض تقطع about 1 سنتيمتر of the nerve. بس الحقيقه احنا في المركز لا ما بريزيرف النيرف لان ده بحب التويتشز اللي بتحصل.
يعني ايه بتقطع 1 سنتيمتر من النيرف؟
هو ده اللي موجود في الليتريتشر. انت you can cut the nerve for 1 سنتيمتر to avoid the twitches of the muscle later on. بس الحقيقه احنا وجدنا ان التويتشز ديت حاجه بسيطه جدا فما بتحتاجش ان احنا ده انفجار ولا ايه؟ So this picture shows the after complete harvest of the flap on the posterior cyst wall, and then the patient is rotated anteriorly to in the spine position. Flap is sutured to the inframammary fold, and the prosthesis is inserted. And this is after complete depistalization and closure and stitching of the latissimus dorsi flap overlying the implant to cover it from all sides. And this is a final result after skin closure. Patient received the radiotherapy, and this picture taken after 6 months of finishing her radiotherapy. So second case is for a 37 years old lady. She had a rare breast cancer. Patient had a mastectomy about 2 years before. Received adjuvant chemotherapy and radiotherapy, and she was under hormonal therapy. She come asking for a reconstruction, did reconstruction. So we have to remove the scar of the mastectomy, also creating a cavity or flaps, upper and lower flaps, and the missing part of the skin should be replaced by other skin. So the plan was to do combined techniques also by latissimus dorsi myocutaneous flap, the skin measured according to the distance between upper and lower flap, and implant is chosen to provide an adequate projection and volume. And here is again the preoperative planning of the latissimus dorsi. Here is after complete harvest of the flap on the back of the chest, and after elevation and reaching the pedicle. This is the back of the chest after well hemostasis and closure of the skin. And here is an inframammary fold is created by suturing in the deep dermal and the chest wall. Implant is placed, and again the latissimus dorsi is covering it completely. And this picture just after finishing the surgery, and this one on the right side is after 1 week, and on the left side after 1 month. So at the end, the latissimus dorsi flap and the prosthesis is a popular method for breast reconstruction, particularly in cases where autologous tissue is limited. Combined latissimus dorsi flap and the prosthesis techniques offers a safe and an effective approach to breast reconstruction. Proper patient selection, meticulous surgical technique, and good post-operative care minimize the incidence of complication. Thank you.
Dr. Tariq, now because we are short of time, we'll keep the question till the end of the session. Now may I introduce Professor Mohammed Higazi. Professor Mohammed Higazi from Mansoura University, Mansoura Cancer Center.
مساء الخير، السلام عليكم. بما اننا يعني تقريبا عارفين بعض، يعني دكتور شريف، دكتور ابراهيم، دكتور ايهاب، دكتور احمد، دكتور اشرف، مساء الخير. المسج اللي انا هقولها النهارده هي ظريفه بعد الدسكشن الجميل اللي احنا سمعناه. هو ده كان طلب من الاورجنايزرز. لو انت عايز تقول مسج لل little number of surgeons اللي attending هنا وال large number of surgeons اللي موجودين اونلاين، عايز تقول لهم ايه؟ What message do you want to tell them بالذات في التطور الجديد اللي حاصل في البريست كانسر سيرجري؟ ده احنا It's a long way and long journey from William Halsted 1894 لغايه 2019 ongoing. دكتور شريف اتكلم على التطور الرهيب اللي حاصل. دي الميجور ترايلز اللي عملت التطور في البريست من الهالستيديان ايرا لغايه دلوقتي the new thing. وبدانا نحلم بحاجات كتير قوي، يعني الاول راديكال ماستكتومي، لا موديفايد راديكال، بريست كونزرفنج، وزودنا السبيكترم اوف انديكيشن اوف بريست كونزرفنج. بس طبعا بريست كونزرفنج كان اساسي والراديوثيرابي. كان وي دو بريست كونزرفنج without راديوثيرابي؟ نقدر. احنا يعني ايه، العلم is going very fast and we should adapt this. طب can we eliminate surgery خالص؟ Can we do complete response special cases of luminal subtyping after obtaining complete pathologic response? Do not surgery? Yes, this trial is ongoing, but still till now the standard is doing surgery. What to do in this large area of debate and large discussion? سمعنا الدكتور شريف بيتكلم على multiple lumpectomies في multiple epithelial breast cancer. What is the message for surgeons in oncology centers in all over the country? The first message, this is where we are. This is your task, your job. This is Egypt. They were seeing us in a problem. Despite our low incidence accounting about 50 per 100,000 population, we have a mortality approaching 20 per 100,000 mortality. This is quite the contrary to more industrialized countries like Australia and New Zealand with around 100 incidents but only 12 mortality. We have little incidence with high mortality. We should cover this gap. I mean every surgeon attending or hearing this session. You should encourage Egyptian women to screen themselves to be discovered early, and you should treat them properly in an appropriate way to decrease the incidence of high mortality that is not accepted. Breast cancer in Egypt, not only as you see the contradictory ratio of incidence and mortality, but it is also more aggressive stage. We are full decade younger than the Western Egypt presentation. For example, this is one of our cases which we are going to build the whole presentation upon her. There's a 31 lady, first diagnosis for this huge 7 centimeter mass with, as you see, supraclavian infraclavian lymph node. What to do in this lady? It's quite evident. I will take a biopsy, and this is her biopsy. High-grade infiltrated carcinoma, AR positive, PR positive, negative, bad molecular biology. What to do? The guideline said neoadjuvant chemotherapy. This is her after neoadjuvant chemotherapy. After finishing her 8 cycles of chemotherapy, a complete response occurred despite of the presence of a 5 centimeter mass, looks like a fibrotic tract. Bilateral benign-looking lymph node, only one lymph node infraclav, 5 millimeters for PET and PET with negative. It's a complete response. What to do to this lady? Can we do a breast conserving surgery? Can we do extreme oncoplasty? We have multiple nomograms that can predict bad outcome for oncoplasty or breast conserving surgery. Do not sum 2 of them. Multifocal or suspicion of multifocal disease, preoperative MRI not present, positive N, non-papillary tumor, microcalcification mammogram extensive, preoperative T2 and more, high breast density mammogram in absence of MRI, and DCIS component extensive. So for this lady, we will not do breast conserving surgery. The outcome is going to be bad, despite the discussion, the nice discussion that was performed a couple of minutes ago between and the area of margin after neoadjuvant chemotherapy. Nowadays, therapeutic strategies against breast cancer are increasingly customized for each patient and modulated according to clinical features, staging, biologic factors, hormone receptor status, HER2. An accurate discussion with each patient about the advantage and issues associated with the chosen treatment should always be performed in a correct decision-making way. So the message is appropriate should be appropriate for the patient. What is appropriate? This is the key of this whole lecture. Appropriate practice is one that provides patient benefit. It is effective based on evidence-based. It is efficient based on cost effectiveness. It's equitable and consistent with ethical principles and preference of the individual patient. Inappropriate practice is that may cause harm or provide little benefit to the patient and may be frequently misused in clinical practice. This is inappropriate. We will go back to Our Lady and discuss what is appropriate for her before discussing with her and before she told me what is appropriate for her. So the message is for you, the modern breast surgeon. You should perform the choice of breast conserving treatment versus mastectomy based on breast volume to cancer volume ratio, multicentricity, presence of mammographic microcalcification, ability to achieve clear surgical margins and patient wishes We have a very important SDM, shared decision making. The final decision is for the patient, and you are you are asked to careful evaluation of disease. It's your job by clinical radiological examination is crucial to select the optimal local treatment. So, for you, surgeons on all oncology centers, you should know the phases of breast cancer surgery practice. You have a preoperative phase, intraoperative phase, and postoperative phase. Your knowledge about these phases will qualify you to sit in front of your patient and discuss her, as we said, what is not harmful to you, what will add you benefit, and you can choose between multiple modalities of treatment, what suits your preferences. Preoperative phase, breast imaging and tumor localization, MDT discussion, consider neoadjuvant chemotherapy, and proper selection of your surgical procedure. Intraoperatively, you should localize your tumor, frozen section open cytology available, and clip insertion, and discuss with your peers the radiotherapy issues and chemotherapy issues. We, Kohler Group in Australia, have done a simple toolbox and delivered them to here, its oncology centers, for physicians to memorize them. The first tool, preoperative diagnostic imaging, should do ultramammography. We are going back to basics. Despite I started with you can omit surgery. No, stick back to basics. Minimally invasive breast biopsy, do trocar biopsy. MDT, you should discuss your case with MDT. For non-palpable breast lesions, radioactive seeds, intraoperative ultrasound, wire localization, etc. Oncoplastic techniques can reduce the need for reoperation. Specimen orientation, talata or more margins. Specimen radiograph with surgeon intraoperative view. Consider cavity-shaped margins in patients with T2 or greater tumor size, or with extensive DCIS component, cavity-shaped margin, not lumpectomy margin. In these tumors, do cavity-shaped margins. Intraoperative pathology assessment by frozen, and stick, as we said, to the ASTRO margin guidelines where no ink in tumor is quite enough. There is nothing called is more better. No, in oncology, in breast cancer surgery, no, more is no more the better. And finally, routine breast-specific patient-oriented outcome measurement may help to assess cosmetic outcome. Tailor your treatment according to the needs of every patient. Translating these, you, again, surgeons in oncology centers in Egypt, all over Egypt, needs dedication, persistent data language, evidence, and good practice. First rule, triple assessment. We all know triple assessment. Do not only examine your tumor, assessment of general health status. The host is very important, primary tumor, regional lymph nodes, and metastatic disease. You should be familiar with the preoperative localization method techniques like carbon marking, like wire localization techniques, like clip marker after stereotactic or vacuum assisted. And we have discussion nice of the new methods of silver wire or clips. It is not appropriate to perform unnecessary investigations, do ultrasound, do mammogram, as we said, and know the indications of MRI. Who are seeing an abuse of MRI, fibroadenoma at 10 years, do MRI. What? No rationale about that. You should do not exhaust the resources in unnecessary investigation. Know the indications of breast MRI, assessment of breast implant, occult primary, measurement of response in adjuvant chemotherapy. And after knowing this and asking the important radiologic tools, you should know simple, these are examples. If you find an intramammary lymph node, what is the significance of intramammary lymph node? Again, the message is, if you are a modern surgeon, not only do or ask for the proper radiology, but you should know its meaning and its translation into your clinical work. Intramammary lymph nodes, it offers a worse prognosis. If you are conflicting between adjuvant chemotherapy or ion found, it carries a worse prognosis. Pathology issues, you should know what is the meaning of the pathologic types, what's meant by infiltrating globular carcinoma, what's meant by metaplastic carcinoma. You should know that lobular carcinoma may metastasize to meninges, to gut, and you should ask for the proper investigations for this. Metaplastic carcinoma, our nightmare, that was not known until around 20 years ago. You should know it. It is a quite tricky tumor. Luminal typing. One of the simple tools that may reflect this, your demand to know pathology, you know that there is a very good and important time from handling your specimen from the OR to the pathologist to do accurate ER testing. It is not uncommon that you do ER and in a lab and it result. Another lab, another result, and so on. There is two things called warm ischemic time and cold ischemic time. Warm ischemic time is the time from transaction of your blood supply of the specimen. Cold ischemic time from handling the specimen to the pathologist. For ER accurate testing, this cold ischemic time should not exceed 2 hours. From delivering your specimen till the pathologist. To do tiny details may make a difference with your patients. Patient-related issue, after this thorough knowledge of investigations, radiology, and pathology, you should, what you need, do my patient, what do you need? Don't do mastectomy without offering her reconstruction. Discuss with her family planning and fertility. She is also afraid about her kids, her daughters, her sisters. You should offer genetic counseling when indicated. Thorough knowledge of radiology, pathology with small details, and finally meeting your patient demands. This is our language. When we say adjuvant chemotherapy, do it or not do it. See the level, evidence of quality, and the strength of recommendation. If I say inflammatory breast cancer, low quality but strong recommendation. Nice. What about tumor histology, grade stage, estrogen, progesterone, insufficient and moderate? Okay. What about this? High risk, HER2 positive and triple negative. High quality, strong recommendation. So it is now considered malpractice not to do neoadjuvant chemotherapy for these two entities, biologic entities of tumors. This is our language, evidence-based. Do not harm your patient. What about intermediate, moderate? To reduce extent of surgery, accepted, but not malpractice. This is how to weigh your level of recommendations before setting to your patient to do the appropriate. And finally, in the last 30 seconds, what to do to this patient. Our patient from the start, after knowing this, will not do. I have asked the proper investigation, and she was given neoadjuvant chemotherapy, and she's aggressive, and she wants her breast. After sitting with this patient, you are, in my opinion, to do mastectomy. No. I want to preserve my breast. Breast conserving surgery is going to be bad. no, I want my breast. I will try to do nipple sparing mastectomy for you. If the margins from the nipple and from surrounding breast tissue is quite clear, I will put tissue expander for you. And this what was done. Nipple sparing mastectomy, removal of the whole breast and axilla. And as you see, the nipple was attached, it's called skin reducing mastectomy. A very thin pedicle from inferior pedicle carrying blood supply to the nipple and areola, and an expander was put to her. This met her expectations about removing her diseased breast and maintaining her femininity symbol. And thank you.
Professor Muhammad Hagazi, thank you very much for a very illustrative and detailed presentation, and that contained a lot of advice for younger surgeons dealing with breast cancer. I hope they follow these recommendations. And now we'll be moving to our next speaker. We will leave the questions until the end of the session, if you don't mind.
Dilemma of mastectomy in modern oncoplastic breast era. Thank you Dr. Sharif for presentation. أنا عارف إن أنا جاي آخر اليوم والناس كلها مرهقة. أنا هحاول أسرع بقدر المستطاع في البرزنتيشن. أنا عاوز أرجع. هو فين البوينتر مش شغال؟ البوينتر مش شغال. أوكي. طبعا introduction سريعة. It's all started in 1894 لما هالشتاد published his work about radical mastectomy. طبعا شايفين الصورة. Then go to Patty in 1970. Patty introduced modified radical mastectomy. He preserved the pectoralis major. From step to step there was a published work. The published said that there is no difference in survival rate in 80% of patients in 5 years between radical mastectomy and less extensive modified radical. So jumping from radical mastectomy to modified radical mastectomy require publishment, and the publishing said there is no difference. Then على سيرة اوبنهايمر والفيلم اللي حصل اللي هو مع الحرب العالمية الثانية وانفجار القنبلة النووية دخل beginning of nuclear medicine era. لما دخلنا في النيوكلير ميديسن ايرا بدانا نفكر في كونزرفتيف بريست سيرجري اللي احنا نشيل بارت اوف ذا بريست وكونتينيو بقيه الماستكمي بالراديشن هول بريست راديشن. طبعا فيرنوزي شايف في 1985 تقريبا البيجينينج اوف هيز ورك الريكارنس ريت less than 1.5% at 5 years of patient. فبدا ان هنا الايرا تطلع بتاعه الكونزرفتيف بريست سيرجري. كلنا كنا حافظين في بكالوريوس في اي امتحان بنروحه او في اي مكان بالنسبه للسيرجنز يعني وات ار انديكيشن اوف ماستكتومي على طول كده لارج بريست ماس مور ذان تي 2 مالتي فوكال مالسنتريك سنترال بريست تيومر كولاجين ديزيز ريكارنس انفلاماتوري بريست كانسر كونترا انديكيشن فور راديشن. احنا كنا حافظينها كاسطمبه بنسمعها في كل حته بس with progress of medicine و progress of research Servetian, Melvin Servetian, it's American oncoplastic surgeon, published in 2013. He's published about what's called extreme oncoplasty. The conclusion بتاعته larger greater than 5 cm, even لو multifocal, multicentric tumor can go for extreme oncoplasty. الكلام دوت اتأكد ببيبر تانية published ب 2022 extreme oncoplasty expanding indication for breast conservation. The oncoplastic reduction approach to breast conservation benefit for margin control. نفس الكلام تقريبا قاله يازان في البيبر published في 2019. Current evidence point to breast conservation as a being safe for multifocal, multicentric breast cancer when technically feasible and provide that acceptable cosmetic result. طيب ال NCCN بتاعت السنه دي 4/23 قالت ايه؟ قالت في طبعا عندي absolute contraindication for conservation اللي هي absolute indication for mastectomy اللي هي radiotherapy during pregnancy, diffuse suspicious or malignant microcalcification all over the breast, widespread that cannot be incorporated by local excision. معنى equal if I can incorporate by local excision it's no more contraindication. فانا ما عنديش حد في المالتي سنتريك والمالتي فوكال. انا بقى او السيرجن اند هيز تالنت لو يقدر يشيل اكبر كم ممكن ويحافظ على الشكل يبقى دوت it's not a contraindication for mastectomy. طبعا diffusely positive pathological margin. تمام. ونبذه سريعه عن المارجن. لو انا عندي invasive no ankle tumor is enough. دي واضحه في الان سي سي ان ما اقدرش اتكلم فيها. لو عندي دي سي اي اس فقط يبقى انا بتكلم على 2 مللي is the least margin to be least acceptable margin. تيجي بقى نقطه مهمه جدا السكين. انا شايف الحاجه اللي بتحدد لي انا هعمل ايه في العيان ده الريليشن between tumor breast size and the skin. نيجي بقى في ال NCCN 4/2023 قالت ايه؟ قالت for patient with skin or chest involvement prior to preoperative systemic therapy اللي هو neoadjuvant breast conservation may be performed in carefully selected basis على اساس ال MDT. يعني اللي even with skin affection I still go for conservation. ده NCCN اللي بتقول الكلام ده مش انا، ده معمول عليها studies طبعا الكلام ده، ولكن المناقشات تتم في ال MDT مش على طول. ما يبقاش راي ده العيان ده عنده بوترانج اكستنسيف بوترانج جو فور كونزرفيشن، لا هي لوكالايزد ونتناقش فيها. تاني again what are the indication of mastectomy in breast cancer patient. بس انا زودت كلمه nowadays large tumor more than 2 سم مع الاسف no more. multifocal is no more an indication. multicentric no more contraindication or no more indication for mastectomy. Central breast tumor is no more indication for mastectomy. Collagen disease, we can go for collagen advice, rheumatology advice, and they said nowadays it's no more a contraindication. Recurrence, what about recurrence? Recently, if the recurrent breast cancer, same side, after 5 years, we can go for conservation, but we have to take into consideration the condition of the skin. So if I have a recurrence after 5 years, even in radiated breast, and the skin condition is fine, I can go for conservation on previous conservation. So it's no more an contraindication for conservative. Still, inflammatory breast cancer and contraindication of radiation is still a contraindication for mastectomy, for conservative breast surgery. Choice of surgical technique زي ما انا قلت في الاول tumor factor size و site focality, skin factor, and breast factor size and previous operation scar. اهم حاجه في التشويس اوف سيرجيكال تكنيك سيفتي كام فيرست. احنا اونكو سيرجن، ولو انا بشتغل اونكو بلاستي انا الاونكو جايه في اسمي في الاول، فانا السيفتي از ماست فور ذا بيشنت اللي انا اتبع الجايد لاينز، اللي اتبع السيرجيكال مارجن، اتبع كل حاجه. زين البيشنت بريفرنس زي ما حضرتك قلت، patient preference is very important، فلازم تحط الاثنين تعمل بينهم ويت بين الاثنين. هخش في examples على طول عشان ما اضيعش وقتكم. العيانه دي 42 years old invasive duct carcinoma luminal A N1 received 6 cycle of neoadjuvant chemotherapy. العيانه ديت كان عندها ماس في الابر بول اوف ذا بريست، الماس كانت about 6 سم، فاحنا دخلنا كده في تي 3. عملت لها انا بجين باي inferior pedicle mammoplasty and I perform contralateral breast symmetralization، ودي immediate post operative outcome. انا شايل قد ايه من البريست؟ انا شايل 14 تايم 10 تايم 5 سم، شايل 14 في 10 في 5 سم، وفي النص طلع فيه 2 ماسز لان انا كان عندها مالتي فوكال مارجنز، all margins are free. تمام، وده البوست اوبريتيف اوتكم بتاعتي. العينه دي كانت planned for her mastectomy as she is T3. نيجي في عينه ثانيه 52 years old medically free with right multicentric lesion. انا جايب صوره من الام ار اي. Right breast 12 o'clock 6 cm from the nipple, enhancing mass is noted. فيها clip and on the previously seen right side upper outer quadrant non-mass enhancement. يبقى أنا عندي mass وعندي mass enhancement، والاريا كلها 10.7 في 6 في 7.8. تمام، فدي كان كذا ماس في الupper pole of the breast. على الانفستيجيشن انا بحب exhaust myself in investigation، وانا ليا كده يعني زي ماشي orthodox، يعني ماشي very strict في الانفستيجيشن. once I have two tumor او multifocal or multicentric I go for MRI or contrast study whether MRI or CISM. Once I have a very high density breast من أول ACRC, I go for MRI or CISM. Once I'm lobular carcinoma, I go for MRI. أنا لازم once I'm going to conserve and I'm going to preserve part of the breast, I have to be 100% sure by current situation اللي هي الحاجات اللي عندي دلوقتي اللي بقيت البريست is free. تمام؟ طيب العيانه حطيت فيها مالتيبل واير زي ما احنا شايفين على موست ميديال وموست سوبيريور وموست لاترال، وكان اللور بارشن بتاعتي كانت الاريولا. تمام، وادي الاكسجن بارت بتاعتي مع الاسف ثانيه واحده. وادي الاكسجن بارت بتاعي. احنا قلنا نون ماس انهانسمنت مع الماس كانت about الاريا about 10.7. انا شايل 15 تايمز 17، شايل 15 سم تايمز 17 سم، وطبعا شايل 18 تايمز 16 ده في الباثولوجي ريبورت، والسنترال انا عاملها سنترال انفينود طلعت نيجاتيف، وده منظر العيانه with immediate contractile symmetralization post operative. Another patient نفس القصه برضو مش همشي فيها بسرعه، عندها 5 times 4 سم invasive duct carcinoma luminal A N0 في الupper pole of the breast. I go for inferior pedicle myoplasty، والعيانه دي هنا she refused to touch the contralateral breast and she is respected. قالت لي ما تعمليش contralateral symmetralization، انا مش عاوزه حد يلمس الناحيه السليمه. اوكي، فعملت الانسيجن بتاعتي وعملت البلان اللي انا حتى لما اعمل ماوبلاستي اصغره اقل شيء ممكن. يعني اعمل الوايس باترن عشان الوايس باترن هيديني هركب التيومر هعرف اشيله كويس، واصغر البريست اقل حاجه ممكنه، والديسكريبنسي مش عالي قوي زي ما احنا شايفين. لا انا دي طبعا عليها كونتروفيرسي كتير قوي. العينه دي 37 years old invasive duct carcinoma luminal A، عندها ماس 4 times 3 سم attached to skin not responding to new adjuvant chemotherapy. تمام، ولو انا ركزت في الصوره اللي هي على الحيطه هنا اللي على هنا هنلاقي هنا مكان الاتاتشمنت هنا very near to the skin. اول حاجه جت لنا في دماغنا في العينه دي اول ما شفناها اللي هنا عندي بوتورانج في النبل واريل، وسالنا وعندي ريتراكتد نبل، فسالنا العيانه قالت لي لا انا عندي congenital retracted nipple from time of my birth، يعني هي من كده من الاول. طب البودرانج ديت قالت لي دي حاجه جديده تمام مع ظهور التيومر. الماس كانت في المنطقه الابر اوتر كوادرانت، كانت ماس كبيره تمام، فالماس دي كان اوبستراكتنج الباس واي بتاع الليمفاتكس. فانا البودرانج انا بالنسبه لي العيانه دي تقييمي ليها تي 4 بي. تي 4 بي يبقى انا لازم اكسايز البريست سكين دوت. العيانه كانت ريفيوزنج تماما الماستكمي، وكانت البودرانش away from the site of the mass, so I go for bunch biopsy from the skin. ده pre-neoadjuvant، خدت بايوبسي من السكين pre-neoadjuvant. البايوبسي طلع ما فيه مجرد ما فيه ليمفيديما، ما فيش تيومر امبولاي في المنطقه خالص. so I go for conservation. انا شلت الماس ومعاها الايلاند اللي هي بتاعت السكين اللي اتاتشد ليها زي ما احنا شايفين تمام، وعملت باتش اوف سكين مكان الايلاند ديت، وعملت نيبل واريلا بيز على سوبيريور بيديكال ماوبلاستي. يعني عملت باتش اوف سكين على انفيريور بيديكال ماوبلاستي والاريولا على سوبيريور بيديكال ماوبلاستي. لما نبص على منظر العيانه مجرد about 1 month post operative، العيانه فيري ساتيسفايد بالنتيجه جدا ان هي كانت فور ماستكمي. نخش على طول على العيانه ثانيه 62 سنه، العيانه عندها مالتي سنتريك بريست تيومر، واحد سنترال اند 2 تيومرز اواي في اللاترال بوردر عن الساعه 4 والساعه 5 away from each other. العيانه she is seeking although she is 62 years old she is seeking her breast. So I go for massive resection with excision of nipple areola based على inferior pedicle، وحطيتها على inferior pedicle patch وعملت لها contralateral symmetralization. العيانه دي 62 سنه خرجت من عندي with 2 breasts and she is satisfied. Another 53 years old patient with multicentric upper outer quadrant to upper inner quadrant received the new adjuvant in masses resolved but still masses away from each other تمام. So I go here for same inferior pedicle myoplasty. She took all masses with wires and the wires is obvious inserted in the excised part. Margins, all margins are free as obvious in the frozen section, and here is the post-operative of the patient. Same patient, 6 cm, but here I go for the mass was in lower pole of the breast, so I go for superior pedicle myoplasty. Here is the excised part, too huge. All margins are free. I excise 16 times 14, and the post-operative outcome for the previous patient was marvelous. This patient underwent surgery for DCIS. The DCIS was in lower pole of the breast. She go for excision. Here is the excision scar. Post-operative, the margins was found to be infiltrated by DCIS, and the patient is still seeking her breast. Now I have a problem. Patient was the previous excision was huge, but still marginal infiltrated. So in this patient, I go for a superior pedicle myoplasty. I excise the lower pole of the breast completely, and here is the post surgical outcome. The patient is satisfied by keeping her breast. LD flap, but it's not for complete reconstruction, it's for partial reconstruction. This 41 years old invasive ductal carcinoma luminal A N1 has multiple breast lesion in lateral part of the breast. The patient is young and want her breast, so I go for mini LED flap. From the lateral incision here, I make hemimastectomy for all this area, and I go to resect or rotate the LD muscle from the same incision. There was a question previously about after neoadjuvant, the margins after neoadjuvant. For me, if I am not performing MRI post-neoadjuvant, I go for excision of the presented breast mass. بمعنى لو أنا عندي ماس 5 سم خدت neoadjuvant واختفت تماما وما عملتش MRI قبل ما اعمل عمليه، انا اتليست هشيل 5 سم. انا عارف الكلام دوت مش الابديتد، ولا انا المفروض اشيل على الكليبس وعلى الجديد، والمارجنز بتاعتي المفروض تبقى على بوست نيو ادفنت. بس انا عندي مشكلتين اكشوالي، مش مشكله واحده. اول مشكله اللي انا عشان اشتغل على الجديد لازم اعمل كونتراست ستادي موستلي MRI. باي اكسبيرينس الMRI قرايته مش احسن حاجه، محتاج اكسبرت يقرا لي الMRI عشان يبين لي لو في شوتنج مانر او اللي فيه dispersed تيومر. فانا اتليست لو اقدر اشيل البرايمري سايز بشيله. ما قلتش برايمري سايز زائد 2 سم مارجن، انا بقول برايمري سايز فقط لا غير. يعني ماس 5 سم هشيل 5 سم على الاقل. ده اكسبيرينس وليس جايد لاينز. ارجع للحاله ديت، العينه ديت زي عملنا لها LED flap, mini LED flap from all of the incision was just lateral incision. تمام. عملنا هيميماستكمي، خدنا LED muscle حطيناها لها immediate post operative delayed post operative. تمام. لا دي حاله، دي same patient same place was done conservative breast surgery without anything, just conservation. فبقارن اللي هو لو انا عندي الفكر بتاع LED flap ولو انا بعمل جاست اللي انا اعمل اليبتيكال انسيجن واشيل التيومر، اظن الفرق واضح بين واحده عامله اونكوبلاستي وواحده عامله وايد لوكال انسيجن فقط لا غير. another patient عندها بودرانج في الاريولا، بس دي ما خدناش مع الاسف بانش بايوبسي براير تو نيو ادجفنت كيموثيرابي. رجعت لي بستيل بودرانج في الاريولا او ليمفيديما في الاريولا. الماس كانت بارا اريولال، حطينا فيها واير، شلنا الماس بالنمل واريولا وعملت لها LED وسكين باتش، مجرد ان انا املى البارت ده من السكين من البريست، يعني بمعنى هيميماستكتومي. ده بوست اوبرتيف. سيم بيشنت عندها سكين تاذرنج، خدت LED ماسل ويز سكين وعملتها بالمنظر دوت، وده منظر بوست اوبرتيف. انا دايما عندي افكار الماستكتومي مش بحطها اول اوبشن، بحطها اخر اوبشن. عيانه نفس القصه بالظبط. العيانه دي عندها upper inner و upper outer breast mass. الابر inner فيها سكين اتاتشمنت في الحته ديت، الابر اوتر ما فيهاش، فانا مضطر اشيل السكين اللي في المنطقه دي. العيانه دي لو جات لي من غير السكين اتاتشمنت I will go for inferior pedicle mammoplasty واشيل لها الابر بارت كله، بس بصفه اللي انا هيبقى عندي سكين ديفكت في المنطقه دي فانا ما اقدرش اعمل inferior pedicle mammoplasty او مش هتديني جود ريزلت في العيانه دي. So I go for LED flap with skin patch، وده البوست اوبريتيف اوتكم. تقريبا البريست سايت ما اتغيرش. الناحيه الثانيه كنت معمول لها ميجر داكت اكسيجن، يعني اعتقد الناحيه اللي فيها الكانسر الكوزمتيك اوتكم ممكن يكون احسن من الميجر داكت. ده البوست اوبريتيف اوتكم بتاعت العيانه. تمام. What about central lesion؟ دي عيانه عندها central breast lesion extending to the nipple. تمام. I marked the central breast lesion because there was a small satellite. Obvious here in the CISM, there is small satellite and the mass, and there is extension to the nipple. So from just the circumareolar incision, I go excise the mass and I excise the nipple, keeping the areola, and here is the post-operative outcome. في كم صورة محتاج أوريها. So from the circumareolar incision, I go to excise the breast lesion, excise the nipple, and I closed. Another patient was the same, but here I need more excision. So I go for round block excision, the excision of the nipple, as it's obvious in the specimen. And here is the post-operative outcome. Of course, there is some advanced technique. This patient was presented in MDT. She has right side DCIS, left side multicentric mass. Patient received the neoadjuvant chemotherapy. Left side disappeared completely the masses, and the DCIS, the microcalcification, is still present in the right side. So in the right side, as it's obvious from the mammography, this diffuse microcalcification affecting the upper pole of the breast. The whole upper pole is affected. But if we look to the lower pole, there is no microcalcification at all in the lower pole of the breast. And the patient breast was huge. So I go what's called bracketing. I bracket the microcalcification in the right side. Unfortunately, we didn't mark the left side tumor. If you mark the left side tumor, I can go for conservation. But we didn't mark it, and the patient received neoadjuvant. All masses disappeared, so I can't go for conservation. Here, I go for right side excision of the mass with nipple and areola complex. And for left side, I go for skin sparing mastectomy. Here is the right side. For left side, I go for skin reducing mastectomy with implant. Here is the implant underneath the pectoralis mesh muscle, and I use the inferior part of the breast deep salivation as a sling. Here is the post-operative outcome. By the way, this is reconstructed nipple. It's not her nipple. I make immediate nipple area reconstruction for the right side, and I go for purse string for the left side. And here is the patient. First, this patient was planned for bilateral mastectomy, and here is his outcome after oncoplasty. Another patient, this patient, faulty procedure happened. Presented with upper outer quadrant breast mass, go to general surgeon, he excised the mass, flushed the margin, satellite, and with no axillary staging. This patient received the neoadjuvant chemotherapy. I consider it as neoadjuvant because the breast procedure wasn't completed yet. And come to me. So we have incision, supraareolar. The areola is edematous, and I don't know what's its primary presentation. And I have a small satellite here. So I planned for excision all the mark, the red mark, I excise all the red mark, and I excise nipple and areola also. And I go for inferior pedicle mammoplasty with a skin patch with immediate nipple and area reconstruction. Here is the post-operative outcome for the patient, and here is the artificial nipple and areola. This patient was also presented in our unit in Hermel. This patient has multiple breast masses in the left side. This patient was problematic because I decided for hair conservation. I want to excise this part and this part only. The main problem in this patient that she has a disappeared focus paraareolar at 3 o'clock. So she is multicentric, lower inner, upper outer, and there is at 3 o'clock a mass, a very tiny mass, which disappeared without clipping. So we changed decision from conservation to mastectomy for the left side, and the patient has suspicious mass in the lower pole of right side. So I go for a skin sparing mastectomy in the left side, skin reducing mastectomy on the left side, and just mammoplasty in the right side. And I use implant, and here is the breast completely removed. Immediate post-operative, delayed post-operative outcome. That's if in the same patient, the patient in the right side underwent wide local excision many years ago by traditional wide local excision. She has another primary in the left side. She go oncoplasty, and here is the difference between oncoplastic breast surgery and wide local excision. Thank you.
Thank you, Professor Ahmed Jamal, for a beautiful presentation. بس احنا دخنا يعني. احنا دخنا من كتر الحالات. And the floor is open for discussion. We can have 3 questions if you like. We have Professor Muhammad Hagazi. Does anybody want to ask Professor Hagazi for any additional information?
لا معظمهم واخدين نيو ادجنت، ممكن ما اقولش يعني اخر 3 واخدين نيو ادجنت فور اكزامبل. يعني ده حاجه كده، في حاله اللي حصل فيها نيو ادجنت مثلا واختفت الماس وانا مش عامل وما كانش معمول لها كليبنج، دي الحاله اللي قبل الاخيره معظمهم. اليومينال ان 0 اليومينال اي ان 0 I can do بس it's decision of NDT. هو mostly في اليومينال patient N0 في ال NDT هم بيسالوني السؤال ده، هتعرف تعمل كونزرفيشن ولا هتحتاج تغير تقلل حجم سايز اوف ذا مان؟ فانس ان انا بقول بعرف اعمل كونزرفيشن على الحجم ده يقول لي جو فور اب فرونت سيرجري. هي الدسكشن دايما في التي 2 ان 1 في اليومينال، لان التي 2 ان 1 يقول لك احنا ممكن ندي نيو ادجنت فتعمل دي اسيليشن للاكزيلري سيرجري، ودي برضه بوينت فيها اختلاف شويه. في اليومينال برضو انا بمشي حسب ال دي تي، بس لو هو قالوا لي يعني انا موستلي بقف عند 5 سم اللي هي تي 2، موستلي تي 3 غالبا بناخد نيو ادجنت. Any question?
أي سؤال للدكتور طارق صلاح؟ Combined reconstruction by mycutaneous LD flap and implant.
في الاول حاله حضرتك عرضتها كانت حاله بتاعت الامبلانت وال دي فلاب. اكشولي انا في كذا نقطه مش فاهمه، احنا ليه استخدمنا ال دي فلاب اصلا؟ ما نحط امبلانت بس؟
لان البيشنت المفروض انها بلاند انها تاخد ريديو ثيرابي. انت عايز حاجه بروتكشن للامبلانت.
شبكه. دلوقتي بيتكلموا على سكين تو امبلانت.
كل الريزلت اللي عندنا اللي احنا استخدمنا فيها الامبلانت دايركتلي كفرد باي الترا برو مش اللي هو كنا احنا بنستخدمه او دايركت سكان، الريزلت بتاعتها مع الريديو ثيرابي ما اعرفش هل دي مشكله عندنا في الريديو ثيرابي لا، بس الريزلت مش احسن حاجه. السكين انفكشن عالي جدا، امبلانت كل الكومبليكيشنز شفناها معاها. فاللي احنا لما جربنا الدايركت كفرج باي ال دي تقريبا ما فيش كومبليكيشنز خالص الامبلانت بتحصل معانا.
ما اعرفش هي ممكن يكون فرق في الاكسبيرينس او فرق في حاجه، بس احنا بنستخدم عندنا الترا برو مش.
الحاجه الثانيه كمان دايما الفلاب مع الفات بيدي سنسيشن مع الامبلانت بيساتسفاي البيشنت. بايه؟ بيساتسفاي البيشنت نفسها، عكس الامبلانت تبقى خايفه منها دايركت تحط ايديها كده تقول لك انا حاسه بحاجه غريبه. وفي مشكله تانية بتقابلنا ان كتير من البيشنتس اساسا بيرفض الامبلانت اساسا.
ما دي قصه اخرى.
لا دي كتير جدا يعني.
وانس انا فتحت وانا معايا امبلانت بصراحه انا لو انا هبريزيرف ال دي فور نيكست سيشن. انا دايما بحط العينه ممكن يجي لها ريكارنت واعمل سيشنز اخرى، بحط في بالي كده.
بس هي دي كان كده احنا عاملين ماستكتومي، فنسبه اللوكال ريكارنس بتاعها قليل جدا، وهي كانت على فكره كان هي اليومينال مش تريبل نيجاتيف ومش هير تو بوزيتيف.
السؤال الثاني، حضرتك خدت سكين ليه في ال دي؟ انا ما لقيتوش محطوط في اي حته.
لا انا قلتها وانا بشتغل، انا بحافظ على السكين بادل لو انا احتجت الايرور، لان انا ببعت فروزن سيكشن ممكن ما تردش عليا في ساعتها، فانا باخد السكين بادل لو انا احتجت ان انا هشيل النبل ايرولا هيكون ستراكت باي نيو ايرولا. لكن لما باجي بشتغل في الانتيريور على البريست انا بعمل دي فيزيشن كده كومبليت للسكين.
انا قصدي كان ممكن نفتح ستريت لاين، ممكن ستريت لاين على الباك من غير ما نعمل اليبتيكال لو انا بشتغل.
هي كان عندها هي الميزه في البيشنتس دي ان هي كانت عندها لاكستي كويسه في السكين، وعندها باد فات محترم جدا، فهو بالنسبه لي ما كانش دي عائق خالص ان انا اخد بالتيبل سكان، ما فرقتش خالص معايا. لكن طبعا في حالات كتير لا، لما بتكون انت بتحس ان السكين تايت او كامله، انا بعمل جاست انسجن وبالسكت.
مش محتاجه سكين، مش محتاجه الكتريكال.
بالظبط.
شكرا.
فده الفرق. Out of
It was proved it was proved في الحالات اللي هي كانوا بيعملوها سكالب ريكونستراكشن، لقوا ان بعد سنه المكان اللي اتعمل بيتحرك، بيحصل لها اتروفي والفوليوم اوف ذا بريست از نوت جود. فدلوقتي لا اما بيستخدم هو الفيرست لاين اوف ريكونستراكشن على مستوى العالم كله هو الامبلانت ريكونستراكشن، followed by الاوتولوجوس اللي هو الديب فلاب والاذر تايبس اوف مايكروفاسكولار فري فلابس.
انا هبتدي بالسكند كويشن الاول.
الحته دي يعني الشهر اللي فات في الستيتس الدايب فلاب وقع من الانشورنس، الدايب ترام ما عادش، فيعني الفيرست بتاع هيز امبلانت
ما سمعناش يا
المحاولات
محمد، معلش ما سمعناش. ايه اللي وقع؟ ما سمعناش معلش.
ترام فلاب الشهر اللي فات. لا انا بتكلم على الويز. الدكتوره بتقول البيزك از امبلانت بيزك ريكونستراكشن which is صح. اقصد الالترناتيفز بالاوتولوجاس ار much decreasing versus perforative flap and so on. But it's a good trial. ردا على سؤال حضرتك ليه بتحط التيسمس فوقه؟ It's a good trial for prepectoral implant. ما عندناش بنحط retropectoral prepectoral، كانوا يحطوا EDM، يحطوا ماسل، يحطوا ديرمال سلينج زي ما انت عملت في الحاله بتاعتك. They are all good alternatives. بس المسج للناس الفيوتشر از فور امبلانتس بجميع انواعه. انا بقول الاوتولوجس ريكونستراكشن شيل البرفوريتور شويه، لكن حته ماسل واخد ماسل ما عادش في العالم كده. ترام فلاب ون اوف ذا موست بوبولار شالت من التامين خلاص.
حضرتك عارف النهارده الامبلانت بقى بكام يا دكتور حجازي؟
هو دي النقطه اللي انا كنت هقولها لدكتور شريف.
دكتور حجازي حضرتك عارف النهارده الامبلانت بقى بكام؟
الموضوع كوست نفسه
25,000 الفرده.
الاكسباندر بذا سيم برايس.
لا الوكيل جاب خلاص.
يعني في زمان انا برضو مش عارفه ايه اللي حصل، كان في حاجه اسمها باكر امبلانت. باكر امبلانت ده كان دبل اكسباندر اند ان امبلانت، وكان بيقعد ويتعمل يعني امبلانت. كان موجود انا اشتغلت بيه، كان موجود. دلوقتي الامبلانتس كلها في مشكله في الامبلانتس.
دلوقتي ما فيش اكسباندر من ولا نوع، ما بقاش في اكسباندر من ولا نوع.
هو السبب ان بره في اليو اس الامبلانت ريكونستراكشن از نمبر 1 ان ده انشورد، فالانشورنس هناك هو اللي بيدفع كل حاجه، ما عندهمش المشاكل اللي عندنا. فعشان كده الامبلانت ريكونستراكشن كوست افكتيف كومبيرد للاوتولوجس. لان
في نقطه ثانيه ان الجراح هناك ثمنه غالي.
ايوه،
فالامبلانت ارخص من الجراح
وبيعملوا كتير. يعني هو ممكن في يوم واحد يحط 5-6 امبلانت، لكن عشان يقعد يوم يعمل perforator flap يعني it takes a lot of time and money.
العكس بقى، بالعكس الجراح ارخص من الامبلانت لان هو بيشتغل.
انجلترا انا ما اعرفش هم دخلوا
يعني انجلترا الايديال عندهم الدياب.
المشكله في انجلترا ان انا فيري ريسنتلي هم دخلوا الانشورنس تو كفر الريكونستراكشن، قبل كده ما كانش فيه، ولذلك هم ممكن يكون انجلترا ايكونوميك سيتويشن زي ما احنا عندنا هنا ايكونوميك سيتويشن.
ليه احنا بنستخدم دايما الكوميتد ريكونستراكشن ويزر عن الديلي ريكونستراكشن؟
لا انا بتكلم على ستيج مش ديلي.
بتكلم على ليه ما بنستخدمش ستاندرد نيبل واريبل.
ماله
يعني مهم جدا للعيان.
طب ما احنا ممكن نعمل نيبل سبيرنج ماستكتومي ونحط تحتيها اكسباندر. ايوه عشان الراديو ثيرابي بروبلمز.
ايه الفرق بين الراديشن اوف اكسباندر والراديشن اوف امبلانت؟
لا الاكسباندر
المشكله ان الراديشن مش هيبوظ البروسيسز، الراديشن بيبوظ الجلد. فان انا احط تحتيه امبلانت او احط تحتيه اكسباندر او ابتدي الاول باكسباندر وبعدين امبلانت.
لا انا
هو
بحافظ
المشكلة
على
في الجلد.
الجلد زي ما هو. لا انا مش بتكلم على ديليد ريكونستراكشن.
يعني
هي
ايه
عينه عامله
الفايده ان انا ابتدي باكسباندر وبعدين اغيره بامبلانت؟